History of nurse anesthesia goes way back to the Civil War. We're the first group associated specifically with anesthesia, although the early days of anesthesia, they would grab whomever they could to give anesthesia, and they would train them real quick in open drop ether, and it was often physicians that were students, interns and residents, nurses, and for the most part. But nurses become to specialize more and more in it, and the earliest one being recognized as early as 1861. Alice McGraw became famous in the Mayo Clinic because the Dr. William and Charles, the two Mayo brothers, physicians that started that, had her in charge of anesthesia, and Charles Mayo gave her the title Mother of Anesthesia. And later, she published a number of articles starting in 1899 that were published in multiple medical journals, which helped the profession of nurse anesthesia claim this for nursing as a profession. And she also organized the first school. We have another nurse later that established also a school in 1915, and she was the founder of our National Association. The last point I would make about this that I can't help but be a little proud of as a nurse anesthetist, you'll see that the ASA, the American Society of Anesthesiologists, was founded in 1945, and that we, as an organized profession nationally, started in 1931. And we were the predominant group for a long time, especially during the World Wars. This is Agatha Hopkins, I believe, the one that was in World War II. One of these is, and later she established a school, and then they started the AANA in 1931. There she is. So the wars really contribute to the training of nurse anesthetists, and in World War I they formally started training them, and this machine looks kind of like the ones I was using recently in Afghanistan. And about the same, and they had the same. Nowadays we have a lot of monitors. The first thing I was struck with when I went there to do anesthesia and train was all they had was their finger, a non-invasive blood pressure cuff, and they didn't even have the inhalation agent to go in the machine. So they were using a lot of IV medicine and still intubating, which was interesting, and a lot of ketamine, which I consider more of a veterinary anesthetic. So nurse anesthesia today, we continue to grow. We had the association, the formal certification came. And so let's just talk a little bit about the picture of nurse anesthesia today. As I think most of you know, you need a bachelor's degree to go on because you have to get a master's. Right now it's in a master's framework. To be accepted, you have to usually have good grades in the sciences, have 1 to 2 years ICU experience, or CCU, sometimes ER. It depends a little bit from school to school. And then you go through a master's program and then pass the national certification exam. There's going to be a doctoral framework originally in 2015, and that was changed to 2025 recently for the nurse anesthetists because they're not they want to do it right, and they don't like others really deciding those things for them, I guess. I don't know, but advanced nurse practitioners as a whole nationally agreed on 2015. I don't know if they're still going for that or not. But a lot of our schools will be in the doctoral framework far before then, but 2025 is when that'll be the entrance into practice as a doctor. It'll be a clinical doctorate. And the programs right now are 20 to 36 months. Most of them average about 30 months. We have about 100 programs nationally. People say, well, patients sometimes ask me, what's the difference between a nurse anesthetist and an anesthesiologist? And I usually respond, well, physician anesthetists and nurse anesthetists have the same training and they do the same things. Legally, in all 50 states, for the last 150 years, there hasn't been any restriction, anything that a physician, anesthetist, or anesthesiologist, they want to save that word for themselves, even though I don't see any reason why they have ownership of it. It's just one that studies anesthesia. But there hasn't been any time during that period that we've been limited in our practice. So if you do nurse anesthesia, the only limits to your practice will be thrown up sometimes by local policy in the hospital that you're in. Of course, most large medical centers, you'll work under an anesthesiologist. Often that is a very cursory oversight, and you'll be very independent, depending on the practice model in that hospital. They will still have the authority to sign your charts or review your anesthetic plan. In a lot of the small hospitals, like where I've practiced, they're still the sole providers of anesthesia. So this a little review. We still give about 65% of the anesthetics. In fact, we have about 140 countries that use nurse anesthetists that give about 80% of the anesthetics in the world. And we have some programs here in the States, International Federation of Nurse Anesthetists, that are helping promote that anesthesia training internationally. I know CRNAs that do fluoroscopy, special nerve blocks under fluoroscopy, all type from swan insertion, ICU management, ventilator management, heart, or whatever type of anesthesia you can imagine they do and do independently, as well as in team practice in some of the larger hospitals. So this is a little bit dated. We have about over 100 programs now. The big question patients really have, though, is are you safe, and can you do a job as well as a physician? The title physician and MD has a certain amount of clout. I don't think it'll hurt having a doctorate for nurse anesthesia and other nursing professions. I don't think it's necessarily required, but that's kind of a trend. But I'll come back to that in a moment because I want to mention the Hindenburg. The Hindenburg was the largest aircraft ever flown, over 2.5 football fields long. It would lift about 242 tons. And of course, the Zeppelin company was based in Germany, and they didn't want to use hydrogen. They wanted to use helium. But the United States controlled all the stores of helium, and we weren't too keen on letting the Nazis use it. So they had to substitute hydrogen, thank you. I knew that was wrong. Thank you. They had to substitute hydrogen with a bad outcome, as you can see. So you've probably heard of outcome studies. There's been quite a few big landmark studies done to see, is there really a difference in outcome? And I'm going to back up just for a second, because I didn't want to get too much into this, but when physicians tell their patients, physician anesthetists, that they have more trained anesthesia, it's entirely untrue. They have a 4-year residency, and maybe their only experience out of after McDonald's and medical school, which is nothing about anesthesia, is in their first year of residency is just going around learning to do IVs and rotating through. They only have 3 years of anesthesia training, and the last half year is usually learning about research. That leaves 2.5 years of study of anesthesia. We have the same period of study, if not longer, and out of the same textbooks. We go to the same continuing education, and our certification boards are almost exactly the same. But I'm going to just breeze through these. Basically, all the studies showed that there was no difference in outcome or no appreciable difference whatsoever. Whether an anesthesiologist worked alone or whether a CRNA worked alone or whether they worked together, there was no difference. And the last time that the ASA proposed that we do a major study, the CMS said that based on the previous studies, they weren't going to do another study because anesthesia was so safe today that no more further studies were warranted. But there was one cornerstone legal case that anesthesia was built on where a certain nurse anesthetist, Dagmar, in California, was charged with practicing medicine, and it went to the Supreme Court, and nurse anesthesia won. This is not Dagmar being overcome by Clark Gable in Gone with the Wind, but frankly I don't give a damn because I like the picture, and Gone with the Wind came out in 1939.